Hi everyone, my name is Monica Meacham and I am currently in the Medical Laboratory Science program at Winston-Salem University. My proposal that I would like to present to you today is emergency whole blood transfusion and the successful outcomes when compared to component therapy during a massive transfusion protocol. A conflict of interest may include my current employment as a blood bank technician at Womack Army Medical Center. I would like to start by giving you a little bit of background about whole blood transfusion and where it really started to be recognized for its benefits in the trauma situation. Whole blood transfusion for massive blood loss started to be recognized in the military starting with World War I and has continued throughout the wars. In the battlefield, it is the fastest way to save a life. Soldiers are pre-screened before their deployment to know their blood type, and if their anti-A and anti-B titer levels are less than 256, this allows them to be considered a walking blood bank. If there is a need for blood, the soldier that is considered a walking blood bank can donate to his or her battle buddy within minutes. Although component therapy has been the way for civilian hospitals since transfusion advancement, there are still advantages of issuing whole blood during a massive transfusion protocol. That brings me to the issue that I'd like to present to you today. Advantages of whole blood transfusion compared to component therapy in a massive transfusion protocol have been unrecognized by civilian hospitals due to the limited number of research studies. Today, we will analyze the life-saving benefits of whole blood transfusion and the importance it plays in the event of a hemostatic resuscitation. Traumatic injuries account for more than 5 million annual deaths and are the leading cause of deaths among those under the age of 45. Treatment during an emergency is a time-sensitive issue because most fatalities happen within 2 hours after an accident, making it important to stop bleeding, replace blood loss, and repair the body's hemostasis. Patients who have sustained serious trauma could need massive or large transfusion involving 10 or more packed red blood cells units over a 24-hour period. In some circumstances, individuals in critical condition may need more than 20 blood units, averaging about 5 liters, and this is all within the first 24 hours after an accident. An assessment of blood consumption score, also known as the ABC scoring system, consists of 4 variables: the pulse the pulse greater than 120, the systolic blood pressure less than 90, and the presence of internal bleeding and penetrating torsal injury. Each one of these is assigned 1 point, and a score of 2 or more warrants an MTP activation. Whole blood versus component therapy, the big debate. In present-day practice, physicians typically use component therapy to treat hemorrhagic shock during a massive transfusion protocol to achieve the 1:1:1 ratio of platelets, FFP, and PRBCs, which closely resemble the composition of one whole blood. Compared to component therapy, whole blood uses fewer additives. As an illustration, the amount of preservative solution produced in 6 low-titer whole blood is roughly 378 milliliters, whereas 1,055 milliliters is produced by 6 units of PRBCs, 6 units of FFP, and 1 unit of platelets. Component therapy has a bigger volume than whole blood and fails to obtain the same concentration of blood products and coagulation activities. As you can see on this slide, the comparison, this is 3 whole blood, and this is the amount of components that it would take to achieve these 3 products. As you see here in this chart, the benefits of whole blood has over component therapy when compared to hematocrit, platelet, and plasma coagulation factors. One whole blood, which is 500 milliliters, has a hematocrit of 38% to 50%. Platelets 150 to 400 K. Plasma coagulation factors is at 100%. When you transfuse with the same amount of components as one whole blood, which is one PRBC, one platelet, and 1 unit of plasma, you have a unit that is 335 milliliters with 55% hematocrit. And your platelets you see here, and your coagulation, which is only 80% activity. So in summary, 1 PRBC, 1 platelet, and 1 FFP equals 660 milliliters, which is 160 milliliters more than one whole blood. And you are only achieving a hematocrit of 29%. And here we have 38 to 50. Platelets 88. Here we have 150 to 400. And coagulation activity at 65%. So as you can see, the benefits of receiving one whole blood versus multiple components, and the benefits that you get that will increase your hematocrit, your platelets, and your coag. Theoretically, patients receiving whole blood will establish hemostasis faster, be subject to smaller amounts of non-therapeutic fluid, and reduce morbidity due to an additional direct and concentration supply of coagulation components. In addition to the previous slide, there are logistical benefits for whole blood when compared to components. Utilizing whole blood reduces processing time and equipment requirements. There is no need for centrifuges or plasma expressors to divide the whole blood into components. This also reduces component waste brought on by the separation procedure. Even though whole blood provides all the blood components required in a single product, it only requires refrigeration for storage, significantly reducing the work and the complication for clinical teams. Blood components are different and require multiple storage modes. The PRBCs are refrigerated, the FFP and cryo is frozen, and the platelets are in an incubator that continually rock back and forth. Second, save lives in a massive transfusion protocol. The preparation of the requested units takes time, but depending on the type of unit requested determines how long it takes to get the patient and the amount of time it takes to complete the transfusion. Blood bank has 15 minutes to get 3 RBCs, 3 FFP, and 1 platelet to the patient. But why take the whole 15 minutes when you can cut your time in half by dispensing 3 whole blood units? In a study at Womack Army Medical Center, it took 11 minutes to process components when compared to whole blood. It only took 5 minutes. You can process 2 coolers of whole blood in the same time it would take you to process 1 cooler of components. The research plan that I bring to you today involves using database research to track the patients who have received whole blood transfusion in a massive transfusion protocol in 200 military treatment facilities over 5 years between 2023 to 2028, and compare the results to component therapy issued in 200 civilian hospitals across the United States. We look at the mortality rate in 24 hours and 30 days after trauma. Whole blood transfusions are a reliable, safe product in the event of emergencies for civilian hospitals. After reviewing the data research, you will see that whole blood transfusions will be the quickest and most efficient means of issuing a life-saving product in a moment that requires critical, fast attention from transfusion services. Whole blood transfusions will improve the patient's vital signs, including respiratory rate, compared to component therapy. After 24 hours and 30 days, the mortality rate will be compared to component therapy, and a significant increase in survival will favor the whole blood transfusions. This concludes my presentation. I'd like to thank you for your time. At this time, I'll leave the floor open for any questions or comments. And if you think of any questions later, please feel free to email me at my WSSU email address. Thanks again.